Hey everyone, welcome to NextGen MD with the amazing Dr. Lily Johnston from Southern California. She's here with us. We're supposed to be talking about why do you have PAD? It's a topic we've covered before, but so many questions just continue to come in, and I think it's worth addressing again. But Dr. Lily, right as we were starting into this, I ended up with a call from a PAD warrior who is almost in tears because her ABI was a zero point 0.9 in May and now it's a zero point 0.7. She's been walking more, has fewer symptoms, and you won't believe the difference in testing protocol. The
Say more, Kym.
technologist the technologist, right? Not shocking so far. The technologist would not allow her to remove her genes during the test. Said they do it all the time. And yet her numbers are completely off. And she is just beside herself on this. I ended up messaging a world-renowned technologist, Jill Somerset, and she said, quote, "Good Lord," unquote. No, that should never be done. I just, and this was at a university, and the technologists, "Oh, we do it all the time." You
Yeah,
don't
I think
seem too
that's
shocked.
a great illustration of how fraught some of our testing can be. And it's one thing to say you do it all the time, but if a patient actually wants to get the best information and is willing to disrobe and get the test the same way they had it done the last time, why
Mhm.
wouldn't you let them do that? I don't that part I don't really get. So that's pretty frustrating.
Well, would imagine that you can't even call it laziness because it's not the technologist that's having to be inconvenienced by undressing. It's the patient, and the patient wants to remove their pants. Now, if people are just walking into this conversation, I know we're in the middle. We're talking about protocol for ABI testing, getting the ankle brachial index. Um, do you have any preference if you're guiding a technologist on what you like to see and what you want to, learn from the report? How do you guide them, and how do you guide a patient in making sure that they are getting standard protocol at the very least for ABI testing?
I'm not terribly involved in my own vascular lab here at Scripps Clinic, so I can't tell you exactly what the protocols we use are. What I can say is we're an accredited lab, and I have to believe that we are using standard protocols. And if you just think about a standard blood pressure protocol, right? The most appropriate way to take blood pressure is the cuff on skin. Do
Mhm.
people take it over a thin shirt sometimes? Of course they do. Is it right? Not really. Is it close? Maybe. But the bulkier the sweatshirt, the parka gets, right, the less reliable that's going to be. I have to just imagine that taking an ABI over jeans is less accurate than taking it over bare skin. That just has to be true. So I'm concerned that that's not part of their protocol. And I don't know what the reasoning behind that is, but I can imagine that it might not be a huge deal if you had fairly thin leggings on, but something thicker and much more sturdy like denim is probably going to impact the accuracy and reliability of that testing, and that's a flag for sure.
And I think it's especially important when ABI testing, there can be, you know, false normals. And, especially when it comes to diabetics, we always suggest to a patient, hey, if you can, and you do have access to, and your insurance will cover, we always suggest a leg artery ultrasound.
Sure. And then beyond that, we can look at the waveforms if that's available. We can look at toe pressures. There are a lot of other tools in our non-invasive evaluation of peripheral arterial disease. But I actually want to come back to the first thing you said, which is this patient is feeling better. She's been walking, her distance is improving. And at some point, the ABI number is a little bit interesting, but it's actually the least relevant of all the things we've talked about because for her, if she is clinically doing better, so
Yeah.
what? What if the number is zero point 0.8 instead of zero point 0.9 or zero point 0.7 instead of zero point 0.9? I'm really a lot less worried about that, and especially given what we've just heard about the nature of that test, than I am impressed by her ability to have walked her way to a better clinical place. That's
And
amazing.
that's what she was saying. That's why she was almost in tears because she said, then what good is walking? If my numbers are going to be lower, she's like, I literally would have expected my numbers to be the same or even better because I'm walking further, I'm walking faster, and I feel great. And we always say we have so many patients that come into our groups all the time and they have these tests. They want us to look at the tests and then they go into Chat GPT and upload their tests into Chat GPT, which we highly um we we mm, we don't want you doing that for a lot of reasons. One, your name and your birth date and everything go out into the cyberspace, right? For others to access. I know that seems improbable, but it's still possible. But number two is, as Dr. Lily Johnston just said, it's not just about the test, it's how do you feel? Doctors do not make a decision on whether to intervene based on just the imaging alone. It's it's really your symptoms that truly matter. Right, Lily?
Oh, yes. And the other thing I'll point out is the ankle brachial index relies on flow in 2 out of our 3 tibial vessels. It relies on the dorsalis pedis, which comes from the anterior tibial, one of the arteries that run down the front of the leg, and the posterior tibial, that's the one that runs behind the middle ankle bone. And there's a third one called the perineal. If you are walking and improving your collateral circulation, it may be that you are improving flow not into the AT and the DP or the PT, not the 2 vessels we're measuring through the ABI, but actually into the perineal and the small vessels in the foot that we may not capture with an ABI. I have seen fair number of patients who don't have symptoms, have pretty terrible ankle brachial indices, but still have a perineal that's feeding the foot and keeping that leg alive, and all of the collaterals are not well measured through that ABI test all of the time. So, all that to say, it's still an interesting piece of information. It's worth repeating. But if the number isn't what you think it ought to be because your symptoms are better and you've been walking and you've been improving your nutrition and your sleep and your stress and all the things that we talk about here and you're doing well, please try not to like fixate on that number because you and your body and how your legs feel is truly the thing that matters the most out of all of this.
Yeah, I think she just fears she's having back surgery coming up and is going to be laid up a little bit, for a long, long time. And so she was really hoping that the number would be pretty much close to normal, if not normal, so that she could, feel comfortable and confident in being laid up a little bit. She's incredibly proactive, so already has the foot exercises and everything that she's going to do while she's laid up, but she was hoping to go in with a really good number, a good foundation.
Yeah.
So you can understand that's why really make sure you go to an accredited lab. Number one, and number two, I love that you talk about the toe pressure because still far too many places don't offer the toe pressure, the toe brachial index, the TBI, and I think that that's really important when it comes to PAD, and especially the newer presentation of PAD, which is that bottoms up disease, not just the top down and the bigger vessels, but more that smaller vessel disease below the knee and into the foot, correct?
Yeah, and if you have type 2 diabetes or end stage renal disease, kidney failure, the chances of you having an abnormally elevated or abnormally looking normal ABI when it's actually low because your vessels are kind of lead pipes and they're calcified and they don't compress well. The
Yeah.
ABI relies on that blood pressure cuff to squeeze the vessels shut. But if they don't shut because they're this lead pipe with calcium, the ABI can appear normal even though it's not. And toe pressure, TBI, those 2 things really help us understand whether the flow into the foot is normal or abnormal in our patients with severe diabetes or kidney failure.
So why is the ABI important? Well, it's to test for peripheral artery disease. And you mentioned two of the most significant risk factors of the newer, smaller vessel disease, smaller vessel PAD, end stage renal disease, chronic kidney disease, diabetes. And so let's transition into that discussion about why do I have PAD? So starting with the easy one, which is diabetes, why do diabetics get PAD?
I mean, there are several answers to this question. I think over time, type 2 diabetes is an inflammatory condition. And typically, when we're talking about this, we are talking about patients who have struggled with their glycemic control over the years and have had an elevated hemoglobin A1C or elevated glucose readings for a prolonged period of time. We tend to see this later in the disease process. Same with renal insufficiency or kidney damage. It's a later stage finding, but the persistent elevation in sugar is damaging to the innermost lining of the artery called the glycocalyx. It denudes it, it takes away all the protective features, and then we get micro injury to the wall of the vessel. And the body tries to repair that injury by laying down some pavement to seal over that big pothole, and that pavement is plaque. What it's using, the cement it's using to sort of try to seal off this injured area, becomes a plaque. And over time, elevated insulin levels, which we see in type 2 diabetics in an effort for the body to try to control that sugar, the elevated insulin causes us to retain sodium. That's a kidney function. And once we retain sodium, blood pressure goes up. We will often find that our type 2 diabetic patients have elevated blood pressure as well. That again causes extra damage, stress to the walls of the artery. And over time, again, as that happens, the endothelium is damaged and the body tries to repair that by putting down some plaque. So, plaque is really an adaptive response to vascular injury, and all kinds of things injure the vessel. So inflammation damages the vessel. And when we have type 2 diabetes for a long time, people tend to accumulate fat around the organs, visceral fat. Visceral fat promotes inflammation. So we can see markers like interleukin 6, TNF alpha, many of these inflammatory cytokines or chemicals that float around and tell the body there's a problem, there's something going on, we need to fix this. That can be elevated in our patients with type 2 diabetes. We talked about the sugar damaging the wall of the vessel. We talked about the insulin resistance and the elevated levels of circulating insulin hormone that then cause us to retain sodium and the blood pressure goes up. So we have now at least 3 mechanisms by which the presence of poorly controlled type 2 diabetes can result in damage to those blood vessels.
And so you were alluding to chronic kidney disease as well. So high blood pressure that can definitely, have an impact on the kidneys. Is there anything else, with kidneys that patients should be aware of? People who have CKD and ESRD, end stage renal disease, as to why, as they progress with this disease, that the likelihood that they're going to end up in CLI, advanced stage um, P.A.D., it's just going to be more likely.
Again, when we have trouble with our kidneys, we have trouble with the salts in our blood. So calcium and phosphate are the two that are particularly relevant for end stage renal patients. And again, when we end up seeing the vascular disease of end stage renal patients, there's just a huge amount of calcium that gets deposited in the walls of all the arteries. And
Mhm.
that can be one of those mechanisms that gets the arteries stiffer. They don't respond as well. There's this consistent micro injury. And again, over time, that's a problem. The job of the kidneys is to filter out toxins. And so if our kidneys aren't working, we have higher levels of some of those toxic substances floating around. Well, where are they floating? In the bloodstream, contacting the wall of the vessels, again, potentially promoting damage to the wall of the endothelium and creating this environment where the body has to seal this injury and form plaque.
Let's talk about this vascular inflammation because there's another little culprit called smoking. That can also cause vascular inflammation. Smoking is a huge risk factor. Talk about why.
Smoking creates toxic substances, and it's really beyond smoking. It's truly all nicotine products, and we've teased this out. And I've had some patients and clients express frustration with this because they want to switch to vaping, they want to switch to nicotine pouches. Again, smoking is probably the worst of all of those evils. And if you can switch from tobacco to a cleaner nicotine product, better than nothing. At least you're not getting quite as much toxic. But the nicotine itself is a vasoactive substance. It actually causes constriction of the blood vessels, which is not healthy when our bodies are trying to regulate circulation. The nicotine gets in the way of that regulatory process. but the tobacco also creates, as it's smoked and it burns, right? We get these inhaled carcinogens and toxins. So we are creating this toxic environment in our bloodstream because those things cross through the lung into our bloodstream and circulate around. They damage the vessels. Again, we're coming through this theme of kind of a you know toxic water supply gumming up our pipes, and that's really how I would frame it. But again, the nicotine also does have some vasoactive component to it, and so are nicotine patches the best forever? No, they're not optimal. Is it better than smoking? Yes, it is. And if that's what it takes to get us off cigarettes, great, we'll take it. But if you were to tell me that you're a 25-year-old or a 30-year-old and like is picking up nicotine gum de novo or nicotine pouches, like is that a good idea for your long-term vascular health? My answer is no, it's not. And oh, by the way, we now have pretty good evidence that even marijuana is toxic to the blood vessels. So there are a number of patients of mine who are like, hey, I gave up the cigarettes, but I switched to weed. Is that okay? Well, it might be better, but it's not really okay. It's the lesser of evils, but the best would be to not smoke anything. And
Right.
so,
Because anything you burn and you breathe in, it's toxic.
right. I mean, even air pollution, right? We're starting to see uh, epidemiologic studies that look at the presence of cardiovascular disease, Alzheimer's, lots of different chronic illnesses, and they seem to be increased in places that have a lot of air pollution, whether that is from a big urban environment with cars and trucks and the pollution of a city, whether that is proximity to a forest fire and recent particulate matter in the air from a big burn. Whatever the case may be, it does seem to be that all of these inhaled toxins do add up for us over time.
Now, what about those patients that come to us and they say, I don't understand. I've never smoked. I'm not diabetic. I don't have chronic kidney disease. I don't seem to have a family history. So, why do I have PAD? One of the things we always ask people to check into is autoimmune disorders such as lupus.
Hmm. Yep, that's a great catch. Again, we don't know. I think looking for autoimmune illness is one issue. Looking for inherited risk factors, even if you didn't have a strong family history of events, you could potentially have gotten an autosomal recessive gene that might have been in your grandparents or more remote family members, not just your parents or your siblings that you didn't know about. There are absolutely some inherited predisposing factors for heart attack, stroke, and PAD that way. Um, Lipid disorders, metabolic issues, all of these things can be inciting events, and even a prothrombotic state. So something that predisposes us to clotting disorders can create blood clots, and they don't necessarily have the same plaque build up in the wall of the artery. But I've taken care of a number of patients who showed up with a clot in the arterial circulation. Most people show up with blood clots, quote unquote. That typically means the venous circulation, but not uniformly. I've had many patients who just show up with blood clots in the arterial side, and we don't exactly know. And we go on this big hunt to look. Is it a problem with the heart? Is it a problem with how sticky the blood is? Sometimes we don't even get an answer to that, but the blood clot showed up in an artery in the leg or in the kidney, anywhere in the peripheral circulation, and caused a big problem. And then we have to sort of chase down why. And unfortunately, there are just a few patients where we don't get a satisfying answer to why this happened.
No, but when you talk about clotting disorders, you have, like you mentioned, the heart, AFib, and valvular issues, and even someone with an aortic aneurysm can lead to clotting. And we've seen patients just have clots all the way down, both legs,
Hmm.
in some of those situations. Even more, we've had two patients, and this one's really unfortunate, that have had lung cancer that the doctors couldn't figure out for the life of them why this patient was throwing clots. They tried everything, and the last thing that they tested was for lung cancer. And it turns out that, unfortunately, one was figured out too late. But the other one we were able to actually save by getting them tested. but that is another one. Cancer can do it as well.
Yeah, great point. And it's all cancer. It's not just lung cancer. So if somebody shows up with a blood clot, one of the first questions I always ask is, are you up to date on your recommended cancer screenings? And if so, great. We may still look for other sources of malignancy, especially in a young, otherwise risk-free patient. But that is definitely something that happens that we see.
Um, and there are some hereditary clotting disorders to look for. What are some of the ones that you look for in patients, and why is it that patients in their 50s and 60s suddenly um, are getting clots that are, limiting their ability to walk when it's something that's hereditary? Where were the clots when they were younger?
I don't have a super satisfying answer to
It's
this
a
question. I
loaded
think
question. Yeah.
yeah, I think the most common inherited clotting disorder is typically vein related, and that's factor V Leiden. Some people are heterozygous for factor V, meaning they only have one of the two alleles, and that does predispose a little bit to DVT risk. We don't see a huge amount of arterial clot burden that way. I think atrial fibrillation is probably the biggest culprit for non-sticky blood problems that affects people as they get 50s, 60s, and 70s, and that's a new onset issue. In terms of the inherited things, it tends to be on the arterial side a lot of the autoimmune related. So antiphospholipid syndrome is the most notorious one. We also have protein CNS deficiency. We have a number of these that are potential culprits, and I think as other health issues crop up, as the milieu of the body changes, we become a little more predisposed to some of these events. But I don't have a deeply satisfying answer. And in full disclosure, I am not an expert in clotting disorders. That's a little outside my wheelhouse. But we definitely see that patients do show up with these issues, and sometimes it's that they've had issues for years and they didn't notice because their collaterals
Yeah.
or their other vessels were able to accommodate, and finally this is the one that takes out the whole system enough to where we really realize that there's been a problem that's been ongoing for years. We just didn't know. And if you ask,
Yes.
sometimes they'll say, "Oh yeah, no, I had a little bit of cramping. It kind of went away. Yeah, that went back 5, 10 years." And this is actually a pretty common presentation with things like popliteal aneurysms, where we get a little clot that forms and showers down into those tibial vessels in the lower leg, and it happens for a long time, and then finally the last little piece goes out, and we're really stuck. That's a tough one.
Yeah. And what about those people that say, I have been running marathons. I don't understand. One day I'm running a marathon. The next day I have a cramp that's stopping me in my track. I don't get it. In two cases though, that we have had, they've had a family history of high cholesterol, the hypercholesterolemia. Can't ever say it.
Yeah,
Um,
FH.
but
I mean, we
uh,
know that endurance athletes get cardiovascular disease.
yeah,
It happens, and it presents later than it would if they were not amazing elite athletes, but they're still susceptible to this, and it's not a panacea cure all for this disease process, especially if you have inherited risk factors. If you have certain alleles, certain predispositions, you are absolutely still at risk for this disease. And then
yeah,
sometimes we see there can actually be repetitive damage to the arteries in certain types of athletes. So cyclists, for example, can get something called endofibrosis of the iliac artery, where they end up with a stenosis or a narrowing in the iliac artery that we think is almost like repetitive motion injury. I mean, it's
mm,
repetitive cyclic trauma to the artery that causes narrowing. And when those athletes are so elite, their presenting symptom is they can't go as fast. Like they can't generate 500 watts anymore. Now it's just, 450. And like that's a huge, big difference for them, but they don't have classic claudication. But you do an angiogram and they absolutely have a narrowed artery that is impairing circulation to the lower extremity. So there are all kinds of possibilities in our athletes, but your bigger point is valid, which is yes, being an athlete is amazing and it's great, and it's not necessarily a complete protection against the development of cardiovascular disease.
One interesting one that we just had come into our network last week is a patient um with a heart issue, and she's had it since she was born. And they went in the 80s into her groin to fix her heart issue. And now suddenly she can't walk. And it turns out that from that heart cath that was done through the groin, that it damaged the artery. And over time, she developed the collaterals around it, so wasn't experiencing any pain. But the only part that she has issue with is right there. So it's not your typical, presentation of PAD. I don't even know if you would consider it PAD, but it is treated like PAD. But the patient was asking, she said, I don't understand why they want to put me on all of these PAD meds like cilostazol and stuff when it's just that one spot. Can't we just bypass that one spot instead of having, this revolving door of procedures in this damaged area of my thigh?
Mm. Yeah, that's more common than than I'd like to admit. We see a fair amount of trauma to the arterial and the venous system from procedures that come into the blood supply through the groin. So, vascular surgeons are not the only ones who access those vessels. Also, the cardiologists, the interventional radiologists, lots of people use those vessels. And all of us, vascular surgeons included, can damage that vessel and create issues, especially using the closure devices that we use at the end of the procedure to try to seal up the hole that we made for the procedure. Sometimes we lift up a small plaque from the back wall of the artery that then creates an issue. We can lift up the innermost lining and cause something called a dissection that can limit flow. And you do enough of those cases, then you'll find that. And I had a patient recently who had a cardiac cath, and they didn't treat anything, but they took a picture on the way out, and there was a pretty severe flow limiting dissection. The patient still had a palpable pulse, but it was sort of a back and forth. Should we go in and fix it? Should we leave it alone? And they got an ultrasound that showed a very elevated velocity past that area. And I had a long conversation with her and said, I know you're fine right now, but my concern is that someday, very suddenly, this is going to clot. And all of a sudden, the artery will be blocked. You'll have no perfusion or blood flow in the leg, and that is acute limb ischemia. Your risk of limb loss under those conditions is much higher than it is if we fix this electively. And I know you don't want an operation, and I know you don't want, to stay in the hospital any longer, but I think this is the right thing. So we did. We went in and opened up the artery and fixed that little flap that was there, and she made a great recovery. But yeah, it happens. And I think how you approach that in any given patient is really up to the vascular team who's caring for them. Meds are one option, but yes, going in and fixing the issue is definitely another option.
And for those patients, a lot of these procedures are more durable. And especially if you do a bypass, even a small bypass on these patients, that could last them a lifetime if they're
At
not
that point, it's
susceptible to
really not
PAD.
even a bypass. If it's one focal area, you can just clean out the artery and patch it. I mean, there tends to
You could
be no
patch it.
need for even a true bypass if unless the whole piece of artery is so damaged that you can't repair it. But most of the time when it's a focal
Just
injury
patch.
from a cath, we can just do a femoral endarterectomy and take out the plaque from the
Right.
inside and put a patch over top.
Actually, a really good idea. I might have her ask her doctor about that. She has a great doctor over at Vanderbilt she's going back to. He's chief of vascular surgery. He's a good guy. So, and he's always open for a patient to say, "Hey, I heard about this. What do you think?" Um,
If that's where she's going, I am sure that they have thought about that. I will not be telling them anything they have not thought of.
no, well, I'm sure he will. She's going back because she actually reblocked from going through from a regular just endo
Mm,
wires and balloons. They wanted to just try that first to see if it would do anything and it would maintain, but 6 months later it just didn't. She's like, I don't want this to start. This revolving door. I'm too young for this.
yeah.
But Heinz in our live studio audience on YouTube, which reminds me, always like our video, subscribe to our channel if you can for more great content like this. And Dr. Johnston, what's your YouTube so people can also follow you?
I am at Lily Johnston, MD.
Perfect. So make sure to follow her channel and our channel, The Way to My Heart, and you'll get great content. I mean, who needs TV when you've got our channels? Gold. So Hines is on here. How would a person know whether a blood clot is vein or artery? What test should one ask for? That's a good question because we just had a patient that was in the hospital and they did a venous ultrasound. He has artery issues. They did a venous ultrasound, told him he was fine. I said, and his wife, who's a nursing student, called me and said, um, Kim, he's still having problems. They did the ultrasound. I said, well, what'd they do the ultrasound on? She said, well, they did, let me look, the veins. And I said, but he has artery problems. Lo and behold, the artery ultrasound, what do you think they found?
An occlusion or a stenosis.
Yep. So
Yep.
good thing to know. Great question, Heinz.
Yeah, and the answer is the first step would be the ultrasound, right? And make sure that you're getting both the artery and the vein. They are separate, they are done separately. A very good technologist will sometimes notice one problem while scanning the other, but you can't count on that. I've definitely had patients who came in for a leg problem. They were told they had a blood clot. They did a venous ultrasound, and the tech picked up that, in fact, there was no flow in the popliteal artery at the same time they were doing that venous scan, and that prompted the rest of the workup. But that's a lucky call, and we don't count on that.
And his second question, he's just poking around here. What do you know about advances in gene therapy for familial hypercholesterolemia? FH.
It's coming. It is. It. I think it's coming to trials soon. CRISPR technology is available. I think they are going to target the PCSK9 pathway for that, if I'm not
Mhm.
mistaken. And it'll start with homozygous FH patients. So it'll start in children who end up with total cholesterols in the thousands and end up with very, very severe cardiac presentations, sometimes before their teenage years. So
Yeah.
that's probably where it'll start. And there's going to be a lot of conversation around that and whatever unintended consequences may arise as we move into heterozygous FH and then into a broader population. But I think it's coming down the pipeline sooner than we think.
Fantastic. Did I miss anything in terms of why we have PAD, for this discussion? Have we left anything out? I feel like we've run the gamut.
Yeah, I mean, we didn't talk about sort of atherogenic particles. We touched a little on FH and familial hypercholesterolemia. It was one thing I did not mention when we were talking about how diabetes can result in P.A.D. And that is to sort of circle back to this idea of the particles that put that plaque down in the artery wall to seal over those injuries. So we talk about that inflammatory process and how the body will try to seal that over. It seals it over with lipid particles. And so that is why people are always concerned about LDL cholesterol or LDL particles and also triglycerides. Those both fall under the category of ApoB tagged particles or ApoB containing particles. And those are the ones that will traffic those lipids into the vascular wall, where they become oxidized and then they become foam cells and plaque. So patients with type 2 diabetes tends to have a very elevated number of atherogenic particles, particularly the triglycerides, because as the body is trying to deal with all this excess sugar, it will try to repackage it, and it repackages it as triglycerides. So those are often very elevated in patients with elevated blood glucose and elevated A1Cs, and those particles become a feed forward problem in the artery wall because, again, those lipids get oxidized, meaning they start to rust, and that rust creates more inflammation, which then creates more injury, which then brings more particles into the wall. And you can imagine that continues to feed itself if we don't create a pattern interrupt in there some way. And again, familial hypercholesterolemia, there's a preponderance of those ApoB particles that enter into the cell wall. And over time, some of them become oxidized and again, create this low level ongoing inflammatory process that, unless it is interrupted and stopped, will not stop by itself. So that is
How are
the
we going to
mechanism.
interrupt it? How are we going to interrupt it and stop it?
Right. And
Probably the
this is
next
the
best
role of
question.
lipid lowering therapy for FH, and this is the role of nutrition and lipid lowering therapy for type 2 diabetics. So in our type 2 diabetics, nutrition can make a huge impact on those triglycerides. If we can use nutrition as our lever to control our blood glucose, control our insulin, and ultimately then we bring those triglycerides way down. We bring our whole ApoB load way down, and that is a huge boon for our vascular health. If you have evidence of P.A.D., and you can link to the episodes we have done on statins in the past, if you have plaque in your artery wall, we are going to use an anti-inflammatory medication called a statin to reduce that inflammation, reduce the ApoB load, and try to interrupt that feed forward process of ongoing lipid oxidation in the vascular wall. And
I
again,
like the way
we're going to
you
offer it.
phrase it. I like the way you phrase that because it's too often that statins are associated only with lipid lowered. They're not associated with anti-inflammatory. And that is really the key, is lowering that inflammation. It's so important. But you mentioned hmm, nutrition, and that's highly contentious right now, because RFK came out, and I understand where he's coming from in terms of when we were talking about high rates of heart attacks, right? So long ago, they said, oh my gosh, everyone needs a low fat diet. And it exploded with super highly processed foods on that were low fat. Well, what do you think they replaced them with?
Highly processed
Carbs.
carbohydrates. Yeah.
Exactly. And so now we have a whole other problem. And so I think what he's trying to do, I don't know if he's doing the right way. I haven't really seen his exact protocols yet, but or his recommendations, but I think he's trying to pull us back a little bit. I don't know. But we also want to be careful that we don't want, we were talking to our chief medical officer today, Dr. Michael Danzinger. He's a diabetes reversal expert. And he said, my biggest fear is if they don't do this in the right way, everyone is going to be eating lots of full fat dairy and meat, full fat meat and bacon lard and everything else. So where do you stand, on, or how do you define nutrition, um, when it comes to anti-inflammatory properties and helping people with PAD?
I think we have to consider the big picture of nutrition interventions, because we're not only talking about vascular health, we're also talking about mental health, we're talking about blood sugar control, we are talking about gut health and our microbiome. There are all kinds of reasons that people choose one nutritional approach over the other. We have cultural issues and sensitivities, what the heritage is of our patients, and what they're used to eating and what is culturally appropriate. I have seen people reverse diabetes on a very low fat, whole food, plant based approach. I have seen many patients reverse diabetes on a higher fat, ketogenic, even a carnivore approach, right? I've seen both work. I've seen most people improve markers on all of those different dietary strategies. We are not uniform robots. My body responds differently to certain interventions than yours would, Kym. And so we have to
Mhm.
know what the options are, and then we have to try and see what works for us. And you may not get it on the first go around, but you know, the very low carbohydrate diet, I think, has been maligned by many of the sort of whole food plant forward folks, and that's not entirely inaccurate, right? There's a lot of nuance to this. But if you look overall at a type 2 diabetes population and you put them on a very low carbohydrate diet, by and large, their cardiac risk markers go way down, not up.
Mm.
And there are studies that show that full fat dairy is actually sometimes protective against cardiovascular risk. And processed meat is not the same as a steak. So, don't blame the hot dogs, or don't blame the steak for what the hot dogs did. And
The
so,
grass-fed, grass finish.
and again, like, like most cows are fed grass for most of their lives. How you finish, like there's a whole big conversation here about food processing and our food
Hmm.
environment, and that is a bigger societal conversation that's important. Actually, I think it's really important whether you eat mostly plants or you eat mostly animals. How you raise your plants and animals makes a really big difference, and big agriculture and is not good either way. So the big feedlots are horrible, but so is mass production of, you know, GMO soy and sprayed with glyphosate and all that stuff, right? It kills a lot of
Yeah.
animals to do monocropping and um, industrialized raising of plants. So there is a problem writ large in our food system. To whatever extent Secretary Kennedy can help us get back to a more smaller farm and regenerative agriculture approach, like I think that's lovely. But for
Yeah.
medical practice, as we talk to individual patients about a nutrition strategy, if you hate meat, like an animal based approach is wrong for you, no matter how good it might look on paper for reducing carbohydrate or for reducing diabetes. If you can't stand eating only plants and you are going to forever miss having animal products in your diet, it doesn't really matter if it's the best thing in the world for everybody. If you can't sustain it, it's not going to work for you. So let's come up with a plan that works for you as an individual. And, there is no strategy that is built on cinnamon rolls and Twix bars, right? I know everybody likes that. And so we have to be a little careful about delayed gratification and what you like and don't like. But, within the realm of whole food, there is a wide spectrum of approaches that I think have good scientific basis, and I have seen in clinical practice help patients, and it's not always the same.
Yep. And one more reason why you may have PAD, it might be induced by radiation damage. We have
Mm.
Heinz that has that as an issue. And we've had several patients with radiation damage, particularly in their groin area. And so um, that is another reason we should add. And it's important that your vascular surgeon is aware that you have had radiation, especially if they're going to go in. You have some friable arteries in there, don't you?
Yeah, that's a huge point. I'm glad you brought that up, and thank you, Heinz, for reminding us of that. Pelvic radiation related to tumors, neck radiation again related to tumors typically is those are the two most common places that I will see it. But we absolutely see damage to that artery wall and the subsequent narrowing, and the arteries don't behave normally as well, so they can be higher risk operations or interventions as we try to restore circulation. They don't, and the nerves can get plastered in there. So it's definitely a higher stakes game when we are talking about radiated vessels.
Fantastic. Wow. This was a really productive hour. I appreciate all your time. That was absolutely fantastic. What are we talking about? Oh, wait. LP little a. Did we mention
Yeah.
LP little?
We did not in the we talked about atherogenic particles, and we did not mention specifically LP little a among those things. We talked a little bit about inherited risk factors for early
Right.
cardiovascular disease. I would put LP little a in that category. Again,
Yep.
please check the show notes for our deep dive on LP little a that Kim and I did recently, and you
Oh,
can
it's
check that
fantastic.
out. And we go into much greater detail about that particular little bugger of an LDL particle and how it can impact your vascular health. Yes, that absolutely would count as one of those nasty atherogenic particles that is more likely to accumulate in vessel walls and cause trouble. Also, probably inhibits the breakdown of blood clotting. So, we think there's probably a prothrombotic component, or at least an antifibrinolytic for the nerds
Yep.
component to the LP little a. And that also causes issues. Yep, absolutely.
Fantastic. Whew, that was a great discussion. Please, everyone, like the video, subscribe to our channels at Lily Johnston MD and also at The Way to My Heart for more great content like this. We'll see you back here, same bat time, same bat channel next week.
Sounds like a plan.
Fantastic. Have a great week, everyone.